I'd like to open the floor to any questions, please.
So while everybody's coming up, I'd like to ask a question to begin with. And we can just go down the panel since I know everybody does obesity surgery. Somebody comes referred for reflux disease to your office, and they have a BMI of 42. And what do? Do you talk them into a weight loss procedure? And what do you do if they say yes? What do you do if they say no? Do you want to start, Bruce?
Yeah, I think that patient should get a bariatric operation, and I write the referring doctor a letter to that effect, and I tell the patient that, and if they don't want that, then tell them there's other surgeons who will do their operation. But I really think that that we should do one operation to fix both problems.
I do the same thing. I convince them that what they need is a bypass rather than a Nissen. I show them the data. We do actually have in our practice, we have pretty much a common algorithm that everybody who's morbidly obese should not have a Nissen, but they should have a bypass.
Yeah, I just encountered a similar situation where I had a 71-year-old lady referred to me with a body mass index of 51. And, neither option is particularly enticing, and she's not a healthy 71. But I told her she needed a gastric bypass, and I think an important factor to consider is if the Nissen fails, now you're in an even worse spot, because trying to take down the Nissen and do a gastric pouch with good blood supply is going to be problematic with very high morbidity. So in these people, I really look at that they get one chance at a foregut operation, and if you're going to do it, it should be a gastric bypass.
I agree. One of the hardest operations that I perform are on patient when I'm converting a Nissen to a gastric bypass. Terribly difficult. Yes, ma'am.
Hi, Mary McDonald, Allentown, PA. Thank you very much for some excellent talks. It's all well and good when the morbidly obese patient comes in with a ventral hernia and you tell them, go get a bypass. But in my practice, most of them have already been told that. They don't want one. They have a BMI in the mid-40s. They've got a big gut. Do you refuse to do those patients? Do you say you have to lose 50 pounds? Let's take bypass out of the picture. They don't want it. They've talked to the people. Their insurance doesn't cover it. And many of our underinsured patients or uninsured patients, they don't get bypasses. That's a luxury of the people who have insurance in most cases, and at least in common practicality. So do you say go home and lose weight? And let's just say they're mildly symptomatic. I mean, obviously a very symptomatic patient you would have to do. But in somebody who's uncomfortable, it feels funny, they get gurgling, occasional maybe, nausea from it. Do you refuse to do them and say go home and take Optifast for 3 months?
David, what do you do?
So I encounter this on a almost daily basis in my practice. And what I do is I figure out what the purpose of the hernia repair is. So look at the symptoms, look at the size of the hernia, look at their other comorbidities, and if the real problem is if they have a very large hernia and they are also very large. So one of these gigantic hernias in an obese patient that requires an abdominal wall reconstruction. Let's say they don't have a very large hernia. They have a medium or small sized hernia. I would change my technique. Where I might ordinarily do a component separation, I would just do a straightforward laparoscopic hernia repair. If the sticky situation of a large hernia, large patient, not interested in weight loss surgery, they will not get an abdominal wall reconstruction if their BMI is over 40. Now, having said that, I adjust the BMI and I kind of look at a little bit of excess weight loss. I do preoperative medical weight loss, which has been variably successful, almost uniformly unsuccessful. I've had some patients lose it on their own, and we do a 2 to 4 week liquid diet preoperatively that I learned from our bariatric colleagues to at least do organ shrinkage. And I simply tell them, if they can't lose the weight and they do need an abdominal wall reconstruction, I tell them, listen, if you had to close a suitcase with too much stuff in it, and then you dropped the suitcase, what do you think would happen? And everybody knows it's just going to bust right open again. And they say, well, I get it. So I say, this isn't a judgment issue. It's about trying to do something that we can't really do. And so I might say no.
So I agree with David, and I think the most unfortunate issue is not that much what patients want, mainly because I think you can talk any patient into whatever surgery you want, typically. But if you present it right, it's not talking them into a surgery, but giving them the facts. And if you give them all the facts, the majority of patients, unless they're deadly scared they're going to die from a bypass or something, they will go for what you suggest. The biggest problem is that a number of insurers will not cover the surgery. That's where you're stuck, because you can make the patient go for it, but then how are you going to do it? And I think this is something we probably need to work on, make insurance companies help us in that regard, because I think that's the biggest deficiency. Other than that, if somebody is really obese, typically, and we don't have any other option, I will always suggest the diet. We do have, through our bariatric program, we have a very nice medical side, which will follow them and will put them on very low liquid diets, and they can lose a lot of weight if they're serious about the surgery. And typically they quit smoking, because that's the other requirement we ask them to do. And then we always combine those procedures with plastic surgery, because we do a panniculectomy at the same time if it's a huge hernia and fixing by separation of components.
Bruce, would you like to add anything?
Yeah, well, BMI of 42 is kind of lightweight for my practice. So I would, in that patient who couldn't get insurance coverage for a bariatric operation, it would basically determine if it was loss of domain hernia. If it wasn't a loss of domain hernia, I'd encourage them to lose weight. They probably won't, but then I'll go ahead and fix it if it's really symptomatic. But when you get into the real problem is when you have the loss of domain hernia. And then instead of the suitcase, I use the 50 pounds of potatoes in a 40-pound sack routine, and they usually get that. And you just have to have some kind of weight loss before you can do them. Otherwise, you're just going to be there fixing your recurrence 3 and 4 and 5 times.
Yeah.
Yeah, the other issue to consider is a bariatric operation in a patient with a ventral hernia can be problematic from a where you put your ports standpoint. So doing a gastric bypass in those people can be very, very complicated because you have a bastardized port placement. One of the things that we consider in that situation is sleeve gastrectomy, where it's a little bit technically easier and you don't have to involve any surgery using the small intestine. And even if there's adhesions and hernia defects below the level of the umbilicus, it usually doesn't affect your port placement. You can easily do a sleeve gastrectomy. And we've gotten sleeves approved simply because of the need for weight loss prior to ventral hernia repair. So some of our insurance companies that don't typically cover sleeve agreed to cover it on that basis.
Yeah.
Well, I'm from Massachusetts. Everybody has insurance.
Yes, sir.
Zaman Khan from Hayes, Kansas. I'm not a bariatric surgeon myself, but I got a question. When you say that like a Roux-en-Y would help with the reflux, at the time, would you consider a cruroplasty as well, depending upon their symptoms? Not like a Nissen, but just a cruroplasty at the region of the crura, so it avoids kind of, tightens up the hiatus and...
Just an empiric cruroplasty.
Exactly.
I don't. I look for a defect if I find a repair, but I don't empirically repair the crura. Does anybody here empirically repair the crura?
Yeah, I typically do in that setting because most of these people do have some type of measurable hiatal hernia defect. And I just had a colleague of mine tell me a story of a case he just had a few weeks ago where he had done a bypass in the past and the lady had an enlarging hiatal hernia defect. And the roux limb actually went up into the chest and herniated on itself and became ischemic in the chest. So it was sort of a cautionary tale that if you do see a hiatal hernia defect in patients where you're doing a bypass with reflux as the main symptom, probably a good idea to close the crural defect.
And sometimes you might have an esophageal shortening as well, because of the reflux, so you can free it up. And
Yes.
If there is a hernia, always fix it as well. But if there's no hernia, if that's what you were asking, I'm not sure how.
Yeah, because you look at the crura and you'd explore it and see if, there's a widening of the crura at the time, because going a second time in might be tricky. So that's your best shot at probably doing the cruroplasty.
Okay. Thank you. Yes, sir.
I'm Rabi Kauder from Long Island, New York. Thank you very much. I really enjoyed the tips and tricks in this morning's obese patient session. I just wanted to ask one question for Dr. Schirmer. I'm a general surgeon. In case of perforated sigmoid diverticulitis, large perforation with an abscess or a perforated cancer in that area, the standard currently what we do is to do a Hartmann's sigmoid resection with a colostomy and colostomy. In the obese patient, is that the way you do it, or do you do a loop colostomy and do a 3-stage procedure like the previous olden days? Or because I was always led to believe that Hartmann's is the best way in unprepared bowel and followed by reversal. What are your thoughts on that?
No, I think that's correct operation. I just think it's going to be hard to do a descending colostomy to the lower abdomen, and you're probably just better off doing a transverse colostomy and do a loop, defunctionalize it, because you're going to have to come back and put things back together later anyway. I mean, I don't think you're going to need to do a 2-step operation in those folks, and with a loop and resected bowel, you can do a 2-step. So
you would actually resect the bowel and then do a loop and leave the rest of it?
Right.
And then
or you could, I mean, if you can get up to this, and it's hard to get the splenic flexure in these folks. If you want to try to dig it out and get the splenic flexure out, then just take the whole left colon out and leave yourself with a loop mid-transverse colon. But you usually have enough, the transverse colon's a lot easier to do a colostomy on than the sigmoid in an obese patient. Sigmoid colostomies are difficult, and they're on the downstream side, and they can't manage them, and they're really tough to take care of.
Dr. Earle?
So I'd just like to add that the talk that was in the plenary session today, for perforated diverticulitis, not for perforated cancer, I think that based on the data that exist, as well as my experience of doing the majority of my abdominal wall reconstructions on people that have had previous colon resections for perforated diverticulitis, that you strongly consider a laparoscopic peritoneal lavage with no ostomy for perforated diverticulitis alone. I mean, if a cancer, obviously, you're going to have to resect, but the data show that it works, and you can avoid a lot of the other morbidities of that operation.
That's interesting. Dr. Duncan?
Brian Duncan, Houston, Texas. Nice job by the entire panel. Actually, I have a couple of questions, and I'll throw them out there, and you guys can. First of all, the Roux-Y bypass for GERD. I know that I can't get that improved insurance-wise. I can't. If you mention a bariatric procedure, they assume it can only be done for morbid obesity. So if you have a non-obese, if you have a patient kind of on that borderline of obesity, 35, 36, 38, no comorbidities, what do you do? Second, Bruce, I wanted to ask you about the footboards. I've seen plantar compartment syndromes from heavy patients being positioned, and would love to hear some tips and tricks about avoiding those kinds of issues when you're really using the extremes of gravity to help you with it. And then last question for John was the optical trocars, which I personally love, but want your opinion about using them in the midline versus off the midline. We teach off the midline, so you have those layers to look at, but I'd like to get your opinion on that.
With regards to the obese patient who is between 35 and 40 and who does not have coverage or coverage for bariatric surgery, I know that's going to be a battle, and I get on the phone and I try to preempt all that by talking to the medical director and explaining that basically the natural history in these patients is that once, should we do an Nissen fundoplication, they probably will improve their eating habits and accelerate their weight gain, and then sure they're going to come back and be at a much higher level of risk, and we're going to have a really difficult technical operation to deal with. So do I sometimes win? Most usually I do. Most medical directors can understand that and give me an approval. If they don't, then I tell them to carry on with their PPIs and endoscopic surveillance.
I've had a similar experience because I oftentimes deal with the situation, and typically we'll send a letter. Most of the time we'll get denied, and then you'll have to talk to the medical director, and I typically tell them, if you were your mom, I would do the same thing. I would want her to have this surgery, and that typically convinces them. Most of the time they will approve it once you talk to them, because you know what it has to be done. And sometimes I've told them, if you know better what's better for this patient, why don't you do the surgery for them? And that typically works. No, seriously, I've done that.
Bruce, a question about positioning, I guess?
Yeah. Well, what we do in terms of the footboard, we use a padded footboard, and we get these big styrofoam sort of block type things that the patient's feet go in, and then we tape the feet and put it right on top of the footboard, and that's provided adequate protection. I've not had any plantar compartment things.
Do you use a bean bag or anything to keep them from sliding down the table? Because I think that's really what leads to that.
No, by basically these big styrofoam boot type things, you tape around those, and that kind of keeps the lower leg stiff, and then we put a strap around the thigh, and we have a strap around the thigh to keep that in place, and that usually does it.
One thing, Brian, that I do is I personally perform the positioning on the patient or my fellow, and it's important, obviously, to take all these measures and not put the tape on too tight, because I've had patients who've had some neurasthesias after surgery. But I think and have the same OR team also. I know it's a luxury, but if you can have the same team in the OR all the time, then I'm sure you'll reduce the incidence of such symptoms.
The other key strategy is to make sure that you place the legs in neutral position.
Yes.
Morbidly obese patients tend to have exaggerated thighs, and so as a result, their legs, when they lay supine, are externally rotated, which puts them at risk for a sural neuropathy. So part of keeping them from sliding on the table is to put them in a neutral position and tape their legs that way, and there's really not much room for them to go. And the cases where I've seen the patients slide, their legs weren't put in the neutral position, and I think that contributed to the problem. Regarding the optical access question, I don't recommend their use in the midline. And not only is seeing the different layers of the abdominal wall important to help you understand anatomically where you are, but I worry about a slingshot effect. As you're trying to go through the thinnest part of the abdominal wall, that all of a sudden you'll have like a spear-like effect and plunge into the abdomen and cause an injury. So I think having the multiple layers of the abdominal wall helps prevent you from doing that and makes it safer to identify when you're in the peritoneal cavity.
I'd say I liked David's it was your video on the picture, and I think one of the things that should be emphasized was you're really using a couple of fingers just to twist that thing, not jamming it through the abdominal wall.
Mm-hmm.
I'd just like to add that some of the manufacturers in the package insert specifically say when they use an optical trocar. Well, first of all, I agree with the off midline thing. I never use it in the midline, personal preference, but I think it's safer. But some of the IFUs say that you have to have a pneumoperitoneum before you put it in. Other manufacturers don't, and I bring that up so that you can maybe in your operative reports dictate your experience and why you're doing that and your thought process behind it, because there have been legal cases where there were initial trocar access injury, and they brought out the little package insert and said you didn't use a pneumoperitoneum that was recognized by the manufacturer. I mean, to me, that defeats the purpose a little bit, particularly if you are putting a closed entry port in a patient that's had previous surgery. That's not completely true, but you just have to be aware of that issue.
I also use the optical entry. I'm the only one in my institution, but nevertheless, I do think it's the wrong thing to go midline. Why? Because the typical error with the optical entry is you go too deep, especially early at the beginning. Well, if you're midline, you go too deep, what you're going to hit? The aorta or the vena cava? Congratulations. So why? There's no logic behind it, in my opinion. It's the same thing for varus needle, which I hate because I cannot see. At least with the optical trocar, I can see where I am. With the varus, it's even a blind stick. So I think it's the wrong thing to go at the midline, because the main complication with this entry, the closed entry in the abdomen, is vascular injuries that are very uncommon, but they do happen. So why not avoid it completely and go laterally? And another comment to the positioning of the patient, it's very difficult for those who like to operate split leg tables to do like a Nissen or something on them. So I typically have the bypass set up, even if I do a parsophageal or something, if everything else has failed, to convince them to do a bariatric procedure, and I operate from the right side or the left, because it's very difficult to do it with them elsewhere.
Okay.
So I'm going to be contrarian to the rest of the panel. I never use the optical trocar. And what we do is we use varus needle in the left upper quadrant for our bariatric operations. And the way we get the varus needle in is we use a tracheostomy hook to pull the fascia up and that lets you get the varus needle in very safely and create a pneumoperitoneum.
Yeah, I'm in your camp, Brad.
I would like to
Wonder-
just make a quick comment about the midline versus off midline. And back when it was SG&O, there was a prospective randomized trial about direct trocar insertion. This was without the protective shield versus varus needle and then insertion. And I want to say there was either 125 or 250 patients in each group, and not only were there no major injuries, there was no difference in major injuries. And this is just putting a big, sharp trocar, no pneumoperitoneum, in at the midline, at the umbilicus, by gynecologists. And I think it's not, like many things that we do, it's not necessarily the tool or the technique, rather than the person and how careful they do it. Having said that, there are techniques which are a little more risky than others and lend themselves to a little bit more variability in technical expertise. And I think that going off the midline is globally safer, but there is some data to suggest that it's not.
And most importantly, know all these techniques, because there are going to be situations where what you like to use doesn't work. So I don't think a never statement for any of these trocar techniques is wise. The more techniques you know, the better prepared you are for a variety of situations.
And it doesn't matter if you have a bariatric program or not, you're going to encounter these patients. Well, I'd like to thank our speakers. Thank you very much for helping us out, and thank you for attending.